Hello, good afternoon, everyone, and welcome to this ICIS seminar on whole body MRI, looking at a few important RADS, the ONCO-RADS, the MY-RADS, and the MET-RADS-P. We have an excellent lineup of the usual suspects, if that's the right word, expert in all their own fields in the application of whole body MRI for the various disease types that we're going to talk about today. So before we proceed, I'd just like to, on behalf of the International Cancer Imaging Society, welcome you to this free lunchtime seminar in the UK time. And for those of you who are new to the society, you'll find the range of the society on our website, which I'm sharing on screen with you at the moment. And you will notice that we do offer a range of activities, including our annual conference, which is going to be held from the 12th to the 14th of September this year in Boston. This is an excellent program, and if you're interested in cancer imaging, I would recommend you to come and join us. And of course, the webinar today is a sort of prelude to the main event or another event that we're holding at the end of the year. So we hold a hands-on workshop where you'll be reviewing full DICOM dataset cases for whole body MRI. And we're now into the second edition course this year, and it will be held live in London on Monday, 12th of December. So mark that in your calendar as well. And for other people that you might be interested in also other tumor types, we're also holding a masterclass in pancreatic imaging on the 18th of November 2022. So without further ado, I'd just like to invite our first speaker today, Professor Giuseppe Petralia from the Milan European Oncological Institute. And he's going to set the scene by telling us about ONCO-RADS, the method by which we are using whole body MRI to score abnormality across the body, and in particular, identify what might be potentially cancer from non-cancer tissue. So Giuseppe, please.
Thank you, Mo, and I will immediately start sharing my screen. You just tell me if you can see me well. Okay, so now it's up to me to introduce the topic, and I will discuss the ONCO-RADS guidelines. ONCO-RADS stands for Oncologically Relevant Findings Reporting and Data System. Basically, are guidelines for the acquisition, the interpretation, and the reporting of whole body MRI performed for cancer screening. And a brief introduction to the topic. Whole body MRI, it is a well-established technique for cancer screening if we consider a risk population. By that, I mean carriers of Li-Fraumeni syndrome, hereditary paraganglioma, constitutional mismatch repair, and those with retinoblastoma. And probably the most known is the Li-Fraumeni syndrome. Basically, the TP53 gene is mutated as a mutation, so the guardian of the genome does not work, and the people develop cancer at higher rate. It has been estimated that the females carrier of this mutation, by the age of 30, they develop cancer up to 50%. The lifetime risk in female rises up to 100%. So they need to be screened somehow. And there have been several experiences published in the literature using whole body MRI for cancer screening in this particular population. The most relevant publication that's back in 2016 on Lancet shows clearly that those people who were followed up with annual whole body MRI for cancer screening are represented by the red line. As you can see here, after roughly 10 years, almost 90% of them were still alive, while people who refused any type of screening, represented by the blue survival curve, after 10 years, only 60% of them were still alive. So this shows clearly that these people need a follow-up. This screening could be well performed by whole body MRI. And this provided the basis for the incorporation of annual screening with whole body MRI from NCCN guidelines, Australian guidelines, Canadian guidelines for people carrier ovally from any syndrome. Because on one hand, we have an examination that is 100% safe because it uses no radiation and no injection of contrast agent is needed. On the other hand, we have in our hands a tool which works quite well. These are the figures that we see in literature of whole body MRI to detect primary cancer and metastasis. As you can see here, the sensitivity of whole body MRI in the published meta-analysis that are all included in this table, it is roughly 90% of whole body MRI for primary and metastatic cancer, which is more or less comparable to that of PET, 89%. And the specificity is also very good, 95% more or less, as you can see here in this table, which is again comparable to that of PET. And what is interesting with whole body MRI, we know from these publications that the negative predictive value is again in the range of 95%. Now, another second part of our introduction, we said that it is established whole body MRI for cancer screening in a risk population, but it is increasingly asked in the general population. Whole body MRI is currently offered in health checks in Europe, in Milan, in London, in the US, in Asia, because we have an exam with a good sensitivity, as we discussed before, that can be carried out in a reasonable time. It has no side effects, and again, it has no radiation. And as you can see here on the right on the screen, there are more publications on the topic than you can imagine. And what are the targets? What are the cancers that can be screened with whole body MRI? Here's the list, the cancer figures, statistics of 2022. So this is the top 10. For the big three, as I like to call them, by that I mean prostate and breast for male and females, lung and colorectal, we have luckily very good screening tests. They are already screened. Prostate with PSA, breast with mammography, lung, we have low dose CT that works very well in heavy smokers. We have a colonoscopy for all fecal occult blood test for the rectum. But the other cancers on the top 10 list, they're not screened in any way. By that I mean urinary bladder, kidney cancer, non-Hodgkin lymphoma, liver cancer, pancreatic cancer, and so on. Those cancers of the top 10 who are not screened could be object target of whole body MRI for cancer screening in the general population. And what the literature says, we know, according to literature, that if we start and would like to perform whole body MRI for cancer screening in the general population, we may find incidental findings up to 90%, 99% of cases. By incidental finding, I mean lesions were nothing in terms of oncology, such as cysts, liver hemangiomas, and so on, but still there's something to put in the report. So on one hand, we have a huge number of incidental findings. On the other hand, the prevalence of cancer in the general population, as described in the literature, is below 2%. So there are challenges for us as a radiologist. On one hand, we want to minimize the harm because we know that we find incidental findings in almost everyone. So we should not increase the anxiety of the subjects. On the other hand, we need to pay attention to maximize the potential of the test because it's difficult to find those 2% of cancer in the entire population. So to minimize the harm, what is the instrument? We have to keep well in mind that the negative predictive value of our whole body MRI is extremely high. And there is a beautiful paper that I report here, published by Rouvier, explaining the concept of negative predictive value. The negative predictive value of your test, it works more or less like a filter. So if you follow me on the left of your monitor, if you are using whole body MRI in a staging population, the prevalence of metastasis is high because they're patients maybe with high-risk cancer, so the prevalence of metastasis is high. Metastases in this graph are represented by red stars, while blue dots are negative lesions. So if you apply your filter, your negative predictive value filter, which is whole body MRI, then some of the red stars are filtered through the filter, and the negative predictive value in a staging population, as we saw in the table before, it is roughly 95%. It's still very high. So if we apply the same examination, so in other words, the same filter to a different population, a cancer screening, where we know the prevalence of cancer is extremely low, is 2%. So since the prevalence is low, the red stars, the cancers, are low in the pretest probability. Then you apply your filter, and down, you see that just a few red stars are filtered. So it means that the negative predictive value, if you lower the prevalence of cancer in the population, it must be higher. So we have in our hands an instrument, a whole body MRI, whose negative predictive value must be higher than 95%. In simple words, if we see a negative whole body MRI, we should trust it. On the other hand, we said we want to maximize our potential. Then we need a radiologist able to have to report MRI in multiple areas with oncological expertise, so that they could be able to identify a small cancer. As you can see on the left, there is a small cancer on the right wall of the bladder, and distinguish that cancer from the small bright area on the liver, which is just an hemangioma. No follow-up is required. To do so, we need to have an oncological background, of course, and we have to take into account that there are variations in normal presentation of organs. For example, bone marrow. Here in this image, you can see how bone marrow signal intensity changes over decades. On the left, you start women with 35 years old, 46, 50, 60, 70, as you can see here. You see lower signal intensity with increase in the age. And this has been also demonstrated. It is a very well-known pattern that we should take into account. So just going back to the guidelines, they are ONCO-RADS are guidelines for the acquisition, interpretation, and reporting. And I will guide you into these steps. The first step is acquisition. We tried, all the group, to make some order, because sometimes full body MRI scares radiologists who approach the examination because of the complexity. Well, we try to make it simple. We just need sagittal T2 of the spine, very easy sequence to perform. Then diffusion from head to the mid-thigh or lower in the high-risk population, with just two B-values, B50, B900. Then we need in the same volume coverage, so from the head to the thigh, we need the T1 with Dixon and T2. We like to add for this screening protocol a T2 flare for the brain and a T1 breath hold sequence with high spatial resolution for the lung. I can guarantee you that with a good 1.5 T or 3T MRI, you can complete the entire protocol in 40 minutes. Then there is interpretation. So there is sometimes a confusion on where to start. So we provided some sort of guidance. So we divided the body, the entire body, in 7 regions: bone, head, neck, chest, abdomen, pelvis, and limbs. Then if we find something, if there's a finding, we should locate in one of these 7 regions. And then we need to give a score, an ONCO-RADS category, ranging from 1 to 5. By 1, we mean normal, 2, benign finding highly likely, 3, benign finding likely, 4, malignant finding likely, and 5, highly likely. Just to give you a few examples, here, this man was diagnosed with this mass here, as you can see here, we're in the chest, and this mass is clearly in the T1 in phase, is bright T1 in phase. The fat is suppressed on T1 water. This is clearly a lipoma, homogeneous, entirely suppressed. No follow-up is required. ONCO-RADS 2, because there is something, but it is not highly likely to be normal. No follow-up was required. But on the same man, we observed a lung nodule in the middle lobe, as you can see here, of 6 millimeters. According to the national guidelines, it is required a follow-up at 6 months with a low dose CT. And on the same man, we observed a lesion here on the right wall of the bladder, which was bright on diffusion, dark on NDDC map, was clearly suspicious for cancer. An ONCO-RADS 5 was given. We asked for cystoscopy, which revealed the presence of a low-grade urothelial papillary cancer. Then, in the publication, those were examples. In the publication, we provided other examples, tables, where you can check which are the possible findings for each body region for ONCO-RADS category 1, 2, 3, 4, and 5. So what is possible to find in the head, in the neck, in the chest, abdomen, pelvis, and so on. Third point of the guidelines, we try to address the reporting because we know that it is difficult to report. We do not need to write big books, just small reports, very well organized. We tried to standardize the report by providing templates that you can download for free in the supplemental material of the publication, trying to make reports standardizable and more comparable also for future studies. I added a fourth point in this brief discussion that we have. We also discussed the management of findings, because if we find something, there's an issue, how to manage this. And we know that our reporting and our management should be different if we are dealing with a high-risk population or general population. Because those people of the high-risk population, they need annual screening with whole body MRI. So even if we have a negative whole body MRI, by that I mean not more than ONCO-RADS 1 or 2 findings, they still need by the guidelines annual screening with whole body MRI. So every finding, even if benign, will be followed up every single year. While if we find something ONCO-RADS 3, 4, or 5, we should aim for a biopsy if possible, or dedicated further investigation. While on the general population, we could be more relaxed. We just need to follow the rules that are already well established across the entire body for incidental findings. There are rules how to deal with nodules, the national guidelines, how to deal with pancreatic cyst, how to deal with thyroid nodules, and so on. All these guidelines are summarized in the publication and they're useful for you to check. Last but not least, we stress the point that with whole body MRI performed for cancer screening, sometimes you are the only doctor that the people see. So you have to be a clinical radiologist. In our institution, all subjects who undergo, of the general population, who undergo a whole body MRI for cancer screening, they talk with a doctor before the examination, and we explain very well that whole body MRI is an examination that it is performed in addition to the standard screening. So, and never in substitution of mammography, pap smears, colonoscopy, and so on, just to avoid false reassurance on one hand. And then we speak also after the examination, just to communicate in the nice way the results, to lower the anxiety of the subjects, because we know that anxiety is an issue of any screening, and in particular with whole body MRI. There have been publications on the topic showing that whole body MRI for cancer screening in the general population may increase short-term distress, even if, although it has been demonstrated that the long-term outcome is not bad, and people who were screening in this publication were screened with whole body MRI, and those who were screened without whole body MRI showed no long-term distress effect because of MRI. And we're working on the topic. We have a second oncologist working internally, and the preliminary observation is that when people undergo whole body MRI, there are a lot of bad expectation, and when they complete the examination, the experience in the majority of cases, in 70% of cases roughly, is better than the previous expectation. There are, of course, limitations in whole body MRI for cancer screening. I stress the point that we do not perform whole body MRI for screening breast cancer. For that, we have mammography. So we do not see very well, it's a blind spot, as well as the gastrointestinal tract. We have colonoscopy. So with whole body MRI, we may miss cancers in the gastrointestinal tract. So as a take-home message, I have two main take-home messages. The reports of whole body MRI has to be made clinically. We need to be clinical radiologists. So we have to tailor our report to the risk group. If we are dealing with a risk population, we know that the prevalence of cancer is very high in this group. The lifetime risk of developing cancer is 100%. So we should ask for the investigation if we see something. On the other hand, if we're dealing with the general population, the prevalence of cancer is low, below 2%. So we have to trust a negative MRI and do not over-investigate. And in that particular population, the human interaction is crucial to lower anxiety. So, in other words, there is an opportunity for us to become doctor again, talk with patients, with people, and take the responsibility of onward management, with the idea in mind that early cancer diagnosis, we know, save lives and also cuts treatment costs. Thank you.
So thank you, Giuseppe, for that rapid but comprehensive overview of using whole body MRI for screening. Next, I would like to introduce my colleague, Dr. Christina Messu, and she will be talking to us about using whole body MRI as part of MY-RADS, which is a system that she and a research team has developed for the reporting of patients with multiple myeloma. And the focus of MY-RADS is really for disease detection, and she will explain how you can achieve this by combining MY-RADS with a whole body MRI technique. Christina.
Thank you, Mu. Unless you tell me otherwise, I assume you can see and hear me adequately. These are my disclosures. So I think before I go on to talk about MY-RADS, it's worth just stopping to visualize how far we've come for imaging patients with myeloma, because it's actually our advances in imaging capability that are now substantially driving forward earlier diagnosis for patients with myeloma and actually better clinical decision making throughout the whole patient pathway. So of course, we've been able to now move on from just looking at the plasma cells down a microscope and imaging the secondary effects of myeloma very crudely with skeletal survey, to actually being able to visualize myeloma within the marrow space and gaining a completely new perspective on the disease. And this capability is driving new biomarker-guided diagnosis. So let's just revisit how we diagnose myeloma at the moment. So we still have to establish a histopathological diagnosis of myeloma by proving that there are more than 10% atypical plasma cells from a bone marrow trephine. Now, we can still use the traditional CRAB criteria that we all remember as hypercalcemia, renal failure, anemia, and lytic bone destruction. But what we now have more recently are the SLIM criteria. So the way that these work is if you have biopsy-proven myeloma, so more than 10% atypical plasma cells, and one of the SLIM criteria, we can diagnose a patient with myeloma that needs treatment. And so the SLIM criteria are the presence of more than 60% plasma cells in the bone marrow, or a serum-free light chain ratio greater than 100, and more pertinent to us today, the presence of 2 or more focal lesions greater than 5 millimeters on MRI. So we can diagnose myeloma with a positive MRI, and we don't have to wait for bone destruction anymore. So why are the SLIM criteria better for patients with myeloma? Well, if you think about it, the CRAB criteria are establishing end organ damage. So we end up diagnosing post hoc and treating post hoc, and sometimes that end organ damage is irreversible. What the SLIM criteria enable us to do is to treat before end organ damage. So this is much earlier diagnosis and treatment, which we know leads to better survival and quality of life for patients with myeloma. And if you look at the imaging in the center of your screen there, you'll see just how much disease you can have in the marrow space without lytic bone destruction. So this patient has got a substantial burden of disease that we're only seeing on MRI. Now, having said that, the guidance as to where we should position whole body MRI for myeloma diagnosis is a little bit variable. What the International Myeloma Working Group say, and that's what most centres would follow, I should say, is they say that the first line imaging should be CT or FDG PET-CT. And if that is negative or inconclusive, then they recommend whole body MRI. Now, they do absolutely acknowledge that whole body MRI is the gold standard imaging, but they've also taken a pragmatic stance, acknowledging that availability of whole body MRI is not quite what we would like it to be. So they've essentially, I think, used CT and PET-CT as a triage for who should really be able to access whole body MRI. Now, actually, in the UK, since 2016, our guidance has been slightly different. And the National Institute for Clinical Excellence has suggested that MRI should be first line. And I think they have been more ambitious for our patients and on behalf of our patients, because they have based that guidance on health economics, outcomes, and quality of life evaluation. Now, as I alluded to, not everybody has access to whole body MRI yet. So a lot of centres moved from skeletal survey to low dose whole body CT. And of course, CT is better than skeletal survey. But in fact, interpreting CT in this often older population of patients is actually not always that easy, because differentiating true bone lysis from osteopenia and degenerative change is quite difficult. And actually, when you compare the reliability, the intra-observer reliability of CT with MRI, I think we begin to see that uncertainty, because you see the scores for MRI are very good, but that is not the case for CT. So actually interpreting low-dose CT for myeloma diagnosis is not always easy. So what about FDG PET-CT? Well, we, among several other centres, have shown superiority of FDG PET-CT over so superiority of whole body MRI over FDG PET-CT for detecting both focal and diffuse disease. And the particular study I'm showing you here was prospective with blinded double reads, but we also had follow-up imaging as the gold standard. So we excluded false positives. But I think almost perhaps more interestingly, what this study showed was an association between patients who had diffuse myeloma infiltration with a higher risk genomic profile. So beginning to be able to use imaging to put together that sort of phenotype genotype linking, I think, is a really interesting way forward in us being able to predict the biology of a patient's disease. So with whole body MRI firmly embedded in guidance, a number of us recognise the need to standardise acquisition, and this is MY-RADS. So this was a truly multidisciplinary group of radiologists, MRI physicists and haematologists who had come from centres experienced in offering a whole body MRI service for patients with myeloma. And this is the core protocol. It's a 45-minute protocol with scanning from vertex to knees with no intravenous contrast. And you'll see that it's very similar to the ONCO-RADS protocol and MET-RADS, and that is not accidental. We've tried very hard to keep as many features as common as possible so that centres find it easier to adopt what we think is going to be a very important imaging modality for patients with cancer. There is an extended protocol that allows for introducing Dixon in the coronal plane, an intermediate B value, and also axial T2. But for a diagnostic service, the protocol that you see before you is more than sufficient. And in fact, this is pretty much how I would hang my screen when I'm reporting. So what I'm going to do now is very briefly run through how the different elements of this protocol contribute to the information that we need to help direct patient care. So it goes without saying that we perform sagittal imaging of the spine to detect mechanical complications of myeloma, which can be very morbid. But the combination of anatomy and functional information gives us our best opportunity of characterizing fractures. Now, in the case that you can see here, actually on the sagittal T1, I think most of us would be comfortable that morphologically these are benign end plate fractures, but the diffusion's reassuring. We see edema on the ADC map, also pointing towards a benign etiology. But if we look at the T1 of this fracture, I would have perhaps been sitting on the fence. But if we look at the diffusion, we can see abnormal signal. It's impeded, pushes us more towards a malignant diagnosis, and in fact that was confirmed on kyphoplasty. The diffusion has to be present because it brings sensitivity. It's the most sensitive sequence for detecting focal lesions in the marrow. In this patient, we only found a single lesion on sagittal imaging of the spine, but many more in the vertebra on diffusion. Now, actually, when we detect additional lesions in the marrow on DWI, we do go back and correlate these and find them on our other sequences. And that's an important part of our diagnostic confidence. It's part of the specificity of the technique, but it is the diffusion that brings the sensitivity. I'm just going to touch briefly on response assessment because this is where diffusion really does come into its own. If you look at this lesion in the medial clavicle, you'll see that it reduces in size marginally, but the true insight comes from the ADC. So it starts off impeded, but then returns an ADC equivalent to fluid. So it's a completely treated acellular bone defect, despite the fact that the lesion hasn't disappeared. And those same principles apply when we restage patients, because restaging is also one of the indications for whole body MRI. And in this patient, who had a slight rise in serum biochemistry, we were asked to re-image. You can see they had lots of focal lesions in the bony pelvis on T1, but again, all had an ADC equivalent to fluid, so they were not active sites. And finally, the Dixon brings really good anatomical correlation for us. Here, you can see a very nice, clean rib fracture that I think would have been quite difficult to characterize on the diffusion alone. But of course, we can detect both focal and diffuse disease on Dixon. And we shouldn't forget that it's also a quantitative technique, and we do produce back fraction maps as part of our routine workflow. And sometimes, again, in the response setting, I find Dixon perhaps even more helpful than the diffusion-weighted MRI. So if you look at this patient with diffuse infiltration, we just concentrate on the ADC map before and after treatment, we can see some little islands of high ADC creeping in that reflect cell kill. But if we look at the end of the panel and look at the fat-only imaging, we get a much more profound return of T1 bright marrow fat. So I think that response is more convincing on the Dixon. So the final thing that I'll mention that's in MY-RADS is a suggestion for a clinical reporting template. And I'm not going to run through all of this because most of it's very predictable and it's available in the document. But structured reporting, I think, is important. It makes sure that we don't miss anything. We report in a logical way. And our clinicians find it really helpful in terms of navigating the reports. Now, although the main indication for whole body MRI for myeloma is first diagnosis and restaging, we have included the response assessment category here, but I think Anwar will mention that in greater detail. What I will just point out is that we do recommend that when we're reporting whole body MRI for myeloma patients, we always make a comment about appearances of the marrow in the posterior iliac crest. And in fact, those bone trophines have usually been performed before the imaging. And if you look over here, you can see that we can usually see that trophine tract. Now, the reason we have to make a comment about the marrow in the posterior iliac crest is that because this is where the trophine is taken from, and it's the only place the trophine is taken from, there is potential for sampling error. So these are 4 patients with multifocal myeloma and completely negative trophines. So this isn't just an opportunity to underestimate disease burden. We can completely miss the histopathological diagnosis if we just use the trophine on its own. It doesn't happen very often, but it is possible to overestimate disease burden on whole body MRI. This patient had 90% infiltration on their trophine, but was actually very well, and the hematologist couldn't understand how a patient could have replacement of 90% of their marrow, but yet be so well. And the reason was that the dominant plasmacytoma was in the left posterior iliac crest, and it just so happened that's what the trophine sampled. Whole body MRI, as Giuseppe's already alluded to, is well tolerated by our patients. That's a huge credit to our radiographers who have become experts in patient positioning and communication. But I think also Stuart Taylor's work in the Streamline study is also really insightful in showing that to patients, the lack of radiation is also very important to them. Now, unfortunately, myeloma is not a curable cancer, but the range of therapeutic options is growing, and that means that we have an ever-expanding population of patients living with myeloma. And living with myeloma can look like this: multiple episodes of relapse, lines of therapy, And in our experience, the clinical decision-making gets much, much more difficult over time because the disease becomes increasingly atypical in its presentation. We see more extramedullary disease. The disease becomes non-secretory or asecretory, and so the laboratory parameters become less reliable, and the patients have accumulating toxicity. So relative to the serum biochemistry, over time, the imaging becomes much, much more important for clinical decision-making. And I think as a consequence of that, we can see that reflected in the literature. And I've just pulled out a couple of examples here. So we've seen MY-RADS already validated as a qualitative tool for measuring response in patients with myeloma. And we've also seen it successfully used for detecting minimal residual disease. And it was really reassuring to see the specific statement that the RAC criteria were not time-consuming and very helpful. Now, having said all of that, whole body MRI availability is not where we would like it to be. In the UK, our audits have suggested, this is an audit by another group from UCL, showed that whole body MRI uptake for myeloma patients back in 2017 was about 10%, and it rose to 27% in 2019. So it's getting better, but not where we would like. So there are a number of strategies that we need to employ to support adoption. One of them is education, and ICIS, and you'll hear a little bit more about this, I hope, has done a huge amount in terms of training for whole body MRI. And we have another interactive course in December of this year in London. And so we hope that this effort in training has contributed to increased availability. We've also shown that MY-RADS can be applied prospectively in clinical trials. So the Imagine study that's actually still open, we've demonstrated that it can be run over 3 vendor systems, 1.5 and 3T. And MU-CO is also leading on informatics tools to support radiologist reporting. So this is CE mark software with MINT that allows automatic segmentation and measurement of the burden of disease. But I think perhaps the elephant in the room is that the biggest challenge is a lack of MRI capacity. And our scientists at the Institute of Cancer Research have actually trained an algorithm that reduces MRI acquisition time down from 30 minutes to 5 minutes without any loss of image quality. And we're actually in the process of trying to commercialize that to commercial standards in terms of the software. And our ambition and our hope is that by reducing the acquisition time down, we will be able to democratize access to what we think is a very, very important imaging tool. And finally, I'll just mention some work that's being done on automated QA, QC. At first glance, it doesn't really seem as exciting as accelerated whole body MRI acquisition, but actually, I think it's imperative, because that sort of work will not only ensure that our clinical trial data is robust, but it will ensure that our clinical data is fit for purpose, but also fit for use with the increasing range of informatics tools that will be available to us, but that will require a level of consistency in terms of image quality. So I hope I've managed to convince you that MY-RADS is offering precision diagnostics and really bringing precision medicine to life for patients with myeloma. And I'll just end by acknowledging really an ever-growing community of people that are working very hard to try and bring MY-RADS and whole body MRI into greater practice for patients with myeloma. So thank you very much for your time.
Thank you, Christina, for that, as usual, excellent overview of the subject. So it leaves me now to introduce, or perhaps needs no introduction, Professor Anwar Padani, who has been key in the development of the MET-RADS protocol, or the MET-RADS data reporting system. And in the use of MET-RADS, we're now shifting from merely just diagnosis to using this sort of reporting system to assess treatment response in bone disease. As you're all well aware, one of the problems in oncology is that there are no reliable way of assessing response in bone, except perhaps in the use of whole body MRI, particularly diffusion-weighted MRI. So Anwar, please take it away.
Thank you, Mo. Unless I hear otherwise, I'm going to assume that everybody can see my screen. So I'm going to talk about the MET-RADS system. here are my disclosures. So what is MET-RADS? Well, in the publication, it says metastasis reporting and data system, but I think it's more truer to say that it's a metastasis response assessment and diagnosis system. And it's required, as Mu has just indicated, to overcome the limitations of conventional imaging, particularly with regard to bone imaging. And this, of course, has been covered by Christina just now. So two major themes: detection, so inability to detect disease, presence, and volume early enough to be able to make an impact on therapy effectiveness. And this is what Christina just talked about. But we're also unable to identify who's not benefiting from a therapy early after starting, which means that we impede patients' progress to alternative therapies, which are now increasingly available. And here's an example of somebody that you will have seen all the time. So a whole body MRI on the left in somebody with metastatic castration-resistant prostate cancer. Patient goes on to a clinical trial, and you can see that they insisted that we do RECIST assessment, and you know what? The RECIST assessment was completely stable on subsequent occasions. You can see, because the patient's on a clinical trial, the PSA is blinded. Now, at the end, the clinician said to me, this patient is getting worse clinically, but all the reports are stable. Can we just repeat the MRI? And we did. And you can see how the PSA had in fact gone up, and the whole body MRI shows marked disease progression. So this is a state called unequal clinical progression, which is not that uncommon, in fact, as it turns out, in castration-resistant prostate cancer, if you try to judge what is happening on a bone scan itself. So to try to deal with this, the MET-RADS system was founded, and the first aim was to establish the minimal technical parameters suitable for quantitative analysis, which is why Christina brought up quantitative analysis. And there is a core protocol, but it's more often we would use a comprehensive protocol. So the core protocol plus something else. So what is this plus business? Well, you can see that the Dixon images are done in the axial and coronal planes. There's an extra B value. T2 images are often performed, and we may do other areas. So here's a nice example of a comprehensive protocol, which should take less than an hour. So a T1, a Dixon in the coronal plane, a Dixon in the axial planes with the fat reconstructions, which are mandatory, as Christina just mentioned, and then the spinning MIP image on the right-hand side, and you can see that there are, in fact, two abnormalities. Now, knowing what these, to try to investigate these, you can do a smaller field of view images. So on the left-hand side, you can see this abnormality here on the high B value image, which in fact, on the fat fraction is a high fat fraction. So it represents fat poor bone marrow. This is more interesting because this represents lymph nodes in the left internal IEAP chain. So we did some small field of view here because in this area, because we were interested in giving this cyberknife radiotherapy. In the comprehensive protocol, we almost always do a lung sequence, and you can do it in the axial or the coronal planes. And we will often do a brain examination with a flare sequence, making sure we go from below the jaw to the top of the head without fat suppression. And we do it without fat suppression, one, to identify possible brain metastases, in which case we might give contrast, but also to see things like osteonecrosis of the jaw, which is in fact very common indeed, particularly in women who are on bisphosphonate therapy. So the second aim is to develop criteria that enables you to objectively assess the response of metastatic disease. So objective criteria for the assessment of response. And these are graded from 1 to 5 on a Likert scale. So green to red in this particular instance, where 1 represents response highly likely and 5 represents progression highly likely. So in other words, in this schematic, is it raining? Is it sun shining out there? And of course, if a patient is progressing unequivocally and you want to communicate to to your clinician that there is something they need to think about changing treatment, then basically it's the response assessment category 5 is what you would show. So here, for example, is response assessment category 5 shown on the bottom row. So here we're saying progression is highly likely, and we're all used to looking at the images on the top left, but what we've done is just codify that on the bottom right. Now you'll see that there are no ADC criteria, except any metastatic disease that appears has to be in the active range. And when we did the publication, the active range is between about 600 to about 1100, which you can see on the last row. So this is a person who is obviously progressing. New disease, enlarging deposits, and you can see the whole body diffusion MIP images on the right-hand side. Clearly, this patient is getting worse. The treatment needs to change. This is response assessment category 5. Now, the reason I brought up these histograms is to show you that, in fact, the ADC does not change. So you can see examination number 1, less tumor, a lower histogram. Examination 2, more tumor. But look at the ADC value. The ADC value does not change materially between the 2 examinations. And of course, response requires different criteria. So if disease disappears, more fat begins to emerge, then of course this is response, and I think all of us would recognize it. But another way of assessing response is to look at the ADC criteria, as Christina just mentioned. So an increase in the ADC from baseline is indicative of response. So if we look at response assessment category 1, response highly likely, one of those categories is return of the normal marrow fat. Okay, and here's an example of somebody I saw recently. You can see how on the T1 sequence, the bone marrow is improving with return of the background bone marrow fat and some scarring emerging in the background. So this is response highly likely, response assessment category 1. But there are also ADC criteria. And these ADC criteria relate to the fact that there's an increase in the ADC value. And I just thought I'd show you that here. So this is another man with prostate cancer, before and after docetaxel, this time in the middle of treatment after 4 cycles. We can see these retroperitoneal lymph nodes improving. And if you looked at the T1, it would be difficult to say that this patient was responding, but the diffusion imaging clearly shows us that there is an improvement in appearances. And if you look at the histograms, again, you can see a marked improvement. So this is examination number 1, and we said the ADC value should be low, less than 1500. So here it is. You can see the ADC value up here is 655. And you can see what happens after treatment. After treatment, you can see how the ADC histogram shifts to the left. And of course, it's possible to back map these voxels onto the rest of the body and then get some sort of idea about where there is residual active tumor on this spinning image. Now, as Giuseppe and Christina mentioned, it's important to have a standardized data collection so you can improve communication with your clinical colleagues. So the response assessment categories are about body parts, and you can see the local regional parts on the left, the skeletal parts and the soft tissue parts, and there's a similar form to this in breast cancer also. So for each body part, you have to assign 2 response assessment categories. Now, the primary response assessment category is shown here, is the predominant response in more than half of the lesions in a particular area. So if you were looking at the thorax, for example, what is the major response in that area? And then the second response assessment category is the second highest non-predominant response pattern. Now, let me just show you this patient here. So in this patient, you can see that the patient is progressing, and this is the patient that we saw previously, but you'll notice what's happening in the left axilla. So in the left axilla, you can see that that lymph node is getting larger. So if you look at the response assessment form, you can see other lymph nodes involved, and you go, yes, axilla. And what is the dominant category of the changes here in the left axilla? It's progression, RAC5. All the other lymph nodes, in fact, are stable. So the dominant response assessment category is 5. The secondary category is 3, which is stable, as we've already said. Now, clearly, techniques like this need to be developed further. And one of the things we need to do is to refine, validate these criteria for prostate, breast, and for myeloma. And this has now been done at the Marsden. So, for example, this is some work that was published in 2018, clearly showing that the higher the signal intensity, the lower the ADC, and the lower the fat fraction on the bottom right here, the more likely it is that you have highly cellular deposits. And this has recently been refined by this paper that's, again, just been published in in Radiology. And you can see that if you have a high signal on a high B-value image, low on an ADC map, low on fat fraction, then you are much more likely to have a cellular infiltrate in that area. And that cellular infiltrate would give you enough cells to do next generation sequencing if you wanted to. So this is some really excellent validation from the Marsden that has recently appeared. We are now also aware that the greater the deposits that you see on a whole body MRI, whether you use the MET-RADS system, which just counts numbers, or the volume, the worse is the prognosis. And this has been found consistently in prostate cancer, for example. So the more metastases you have, the greater is the chance that you will have a worse prognosis. So this is an important piece of validation. Some work from Milan has also shown inter and intra-observer variability is in fact excellent to substantial, both for the primary and for the secondary response assessment categories. The real issue is, what is this technology doing in terms of the way it performs compared to bone scans and CT scans? So here is some data again from Milan this time, looking at 31 men with metastatic castration-resistant prostate cancer who got bone scans, CT scans, and whole body MRIs and clinic visits. So in other words, integration into a clinical routine. Now you'll notice that 25 men out of 33 had progressed to the point where you would say, change the treatment. In other words, RAC5, response assessment category 5, change the treatment. And you'll see that progression was only shown on the whole body MRI in about 45% of cases. And no patient had progression shown only on the CT scan and the bone scan. And in fact, when you knew the patient was progressing in the bone, 82% of times, the bone scan was calling things stable. So here's an example. So here's a man. You can see how the bone scan is stable, but the whole body MRI is clearly showing new deposits and progression. So this is response assessment category 5. The patient is progressing. Don't believe the bone scans. And in fact, this completely mirrors what we found in breast cancer also. So in 43 women who were known to be progressing with response assessment category 5 in 33, you can see that 50% of women who were progressing in the bone, either on a CT scan or on an MRI scan, had a bone scan that did not show disease. So be very careful. And this is an example. So here's a lady who is progressing. You can see on the whole body MRI, the bone scan, and there's the report, disease extent unchanged with no increase or decrease in size of lesions. Now, you may look at this and go, well, I can see a bit more. But this was a prospectively reported study showing that, in fact, it's efficacious in terms of treatment switching, and a readout on a whole body MRI scan that comes really quickly. So what is MET-RADS? MET-RADS provides the minimum standards for a multiparametric whole body MRI. So image interpretations, reporting, both at baseline, importantly at follow-up in people with metastatic disease, particularly from breast and prostate cancer in the bone. The validation that I've shown you so far is preliminary. And of course, we need more clinical trials. Remember that RSE4 and RSE5 are going to be useful for drug trials, because in drug trials, people are interested in progression. In early phase clinical trials, you'll be interested in response itself, so stable disease and a definitive response. Clinical care tends to use the entire spectrum. However, we need to remember that clinical value still needs to be determined compared to bone scans and CT scans. Will it truly maximize treatment benefits? Will it minimize undertreatments? Will it enable faster treatment switching and so help patients in the longer term? Will it temper costs and toxicity? Do we know all of this stuff? I don't think we do at the moment. So thank you very much for listening.
Time to bring back the panel, and I believe that some of you might be able to also see the chat in the side box, but I'm going to read out the question. I think the first one is for Christina regarding ADC and myeloma. Do you recommend a particular software to look at how ADC might be changing for response assessment? Not sure that you covered that specifically, but
yeah, I mean, Anwar's probably chomping at the bit to chip in here, because we don't routinely do a lot of response assessment in myeloma, and I have to say, for first-line treatment for patients with myeloma, they nearly all respond brilliantly. Either lesions completely disappear or they become completely acellular. So I don't find a lot of need for it, because it's usually really straightforward. And in fact, when we do our teaching courses, the reason why we put myeloma first often is that the response assessments are so straightforward. The challenge comes with the relapses, where the marrow ends up being very complicated and you're not quite sure if it's relapse myeloma or not. But if I personally need to acquire ADC measurements in my clinical practice, I actually do it on my PACS workstations for individual lesions, and I'm not segmenting whole skeleton at the moment. But Anwar, I don't know if you would want to contribute to that.
Yeah, no, I agree. So even in prostate cancer, for example, we know that PSA works really well for hormone-sensitive disease, but in castration resistance, PSA is not such a good readout, with discordance occurring in up to 30% of cases. So it tends to be more useful for the more advanced disease, as you mentioned previously. And in terms of ROIs, the only time I ever use this whole body MRI segmentation tends to be when there's so much disease and I have to draw so many ROIs that it's just easier sometimes just to do a quick whole body MRI segmentation. But generally speaking, sampling 5 to 6 lesions is usually fine.
okay, I think there's a question about fat fraction, about what cutoff do you use for active metastases versus red marrow. Anwar?
20%. I follow the Royal Marsden guidelines.
Giuseppe, do you want to add to that?
Yes, again, I follow these guidelines. I mean, it works very well in our routine practice, but I stress the point that it has been clearly stated by all the speakers. I stress the point that whole body MRI is an interpretation of both morphological imaging, including fast fraction, and the diffusion with ADC maps. So only by the analysis of all these parameters through multiparametric examination, we can finally say it is response, stability, or progression. So all these parts are equally important.
Yes.
And one more comment, if I can add, following on the 2 previous comments, people are strongly interested in cutoffs, and we identified actually cutoffs that works fine clinically, because the reproducibility of ADC measurements over the bones is quite good. And the cutoffs which work quite well have been identified in the MET-RADS and MY-RADS publication. And I can tell you as a personal experience that I share with the other speakers, they work very well also in other tumors who are typically osteotropic, like breast cancer, who often provide bone metastases. We are running protocols where the cutoffs identified for prostate work more or less like prostate.
Yes. I'm just wary of the time. We have a question, just a comment about how common are whole body MRI being used, or we are being referred to perform whole body MRI. If I may just jump in there, I think, in the, tertiary institution where we're all the speakers are from and the panel members are from, we have a lot of requests for whole body MRI. I mean, we're doing thousands of examinations a year, and clearly the data is compelling. That's why we're doing it. Whether there's enough teaching out there, probably not, and that's why we're always constantly trying to make new courses, such as the one that we're offering later this year to outreach more people. Very quickly, Giuseppe, can T2 Dixon replace T1 Dixon, you think, because you've been playing with both for a while?
Yes, my experience, it could in theory replace it, so it can work. But in my personal experience, I did not find the right sequence. I had some problems in swap of images. So maybe we should work more on the sequence.
And maybe the last 1 minute, because sorry, I have to jump into another seminar for Anwar and Christina. Somebody find red marrow an issue and not able to use the fat fraction. So is there anything you think, a hot tip that might be able to help?
If you don't have fat fractions, and they're easy to calculate, just look at in and a post phase and look at signal cancellation. That usually works well as well.
And Christina, do you want to add to that?
No, I think that's right. And also, again, as we've all said, don't forget morphology. Don't forget to look at the location of the lesion that you're looking at. Where is it? Is it in a site where we expect to get red marrow reconversion? So that the combination of the two, it's all about the functional and the morphological together.
Okay. I'm really, I know there's still questions coming in, and you all have burning questions, but if you're unable to, unfortunately, we are unable to answer all the questions today, but if you are interested in the subject and we're willing to come to London at the end of the year, we've got plenty of live cases to show you on that one-day hands-on workshop. So perhaps we'll see some of you at the end of the year. Otherwise, we'll see everybody at some point, hopefully. All the best, and thank you very much indeed.
See you in Boston.
Bye, everyone.
Bye, everyone.